communities. So by way of introduction, Richard is the Associate Vice President for Strategic Initiatives for Innovation and Research at the University of South Florida and an elected member of the National Academy of Medicine. Julian is a policy advisor and analyst specializing in health, workforce education, social and environmental determinants of health, and global oral health. Their full bios are also in the agenda packet, and so I will refer you to the packet if you want to know more information. So Julian, Richard, I will turn it over to you to moderate our next session.
Well, thank you very much. As one who really does not spend a lot of time in oral health, my background was much more in terms of, I was executive vice president of NYU Medical Center. I started actually in the healthcare field with, some of you may even remember OEO neighborhood health centers, which were primary care centers where we had in one place physicians, nurses, dentists, dental hygienists, community workers, nutritionists, et cetera, all centered around population healthcare. But my main activity has turned out to be one who tries to take science and get it into the practical real world as quickly and as effectively as I can. And that's one of the roles I do at USF with the National Science Foundation program called I-Corps, where we meet with very interesting faculty and postdocs who discovered something, and we now try to figure out how it can really have an impact in the community and move it out there. So this has been a real opportunity, a real pleasure, and a real learning experience for me. So to all of you who spent time and energy and do it every day, I say thank you. For me, the issue is there's no question that the mouth and the mind and the body are connected. We know that oral health has a big impact on health status. And we know that the problem in the United States and in the world is exaggerated in a lot of communities. We say in the United States by zip code, but I've been in villages around the world, mostly Africa, Rwanda, Uganda, Nigeria, and the Sudan. So it could be by villages, it could be by towns, it could be in rural America, it'd be urban America. And we know that it is often not only income or race related, but also resource deserts. And that resource may be health professionals, it may be schools, it may be clean water, it may be food. And we've heard some stories today about that. And so what I'd like you to do for the remainder of the time, and fortunately you'll have a real expert leading it with Julian, but think for the next hour or so, keep all the knowledge that you have, because you know what it takes. You're the researchers, you're people out in the field, you're data gatherers. You know what the problem is, and now we want you to work on a solution, not necessarily from the educational perspective or the interpersonal relationships, or as Anita said, the importance that we know of the integration, the collaboration. Keep that in your head, but now also put into your body that you are a caregiver for somebody 0 to 3 or 0 to 4, and you live in one of these communities. How would you go about solving it? And so think now that you're a mother, a father, a grandparent, a pastor of a church, and you have this responsibility now around oral health. And hopefully you know a little bit more about oral health than I did for my kids, because I didn't think we had to think about oral health until they got teeth, which was interesting, because then I knew what to do. I'd take them to a dentist. But Other than that, I didn't know who to take them to before, but I'm sure you're all better at that. Anyway, so for me, if you can put your mind and where it is and your expertise, but your body now in someone as a parent or a grandparent or a guardian, someone who's 0 to 3 or someone 0 to 3, and then listen to the rest of the presentations and think about how you would solve it for that mother or for me. And now I'll turn you over to the real expert, Julian.
Thank you very much, Richard, and thank you for those very kind words. As I say, my name is Julian Fischer. I'm based here at the Charité University in Berlin, in Germany, and I'm responsible for global oral health and planetary health. And as we've been hearing today, it's a very exciting time for oral health. The WHO at a global level, despite all the major issues that are going on, have said actually oral health should be center of the global health agenda. And that's reinforced by today because we've got participants from 28 countries and all 6 WHO regions around the world. So we really have got a global audience today. And what I'd like to do is quickly orientate, as Richard's been saying, really to shift our thinking now to, we've discussed all the problems, we really now just need to think about what those solutions might look like. And that's really what we're going to be looking and exploring in this next hour. 2 catalysts. The first one, and I think we've been hearing, a lot of the last 2 hours about the impact this new WHO and FDI resolution and definition of oral health have had. And again, it's really reinforcing this connection between the body, the mouth, and the mind. But I think as Dr. Hemmings and quite a few other people on the call this evening have been reinforcing, that it actually goes a little bit further than that. And if you like, the mouth expresses those very deep feelings and emotions, so touches on the idea of soul and spirit. So I'd like to propose that it's the body, the mouth, the mind, and the spirit and the soul that we really need to expand our thinking towards as we look at this new definition of oral health. And if we draw back onto that, those 3 dimensions, this really does shift the narrative. It shifts the narrative from us thinking about disease and no disease, very binary, to this idea that oral health and general health are inseparable. They're indivisible. They are part and parcel of us as people, as we've been saying. And so that allows us to see oral health and general health lying on a spectrum. And that spectrum of health and oral health will shift throughout the life course. It will be impacted, as we've been talking about, the social determinants of health, but it will also be impacted by life events. So people will shift from good oral health to poor oral health over their life course. And then if we again look at the question of those oral health and the life course, as a dentist, and I think Richard touched on that when in his short introduction, as a dentist, I get asked, when should I take my child to the dentist to see you? And I think there, as we've been saying today, we're missing a really critical opportunity. And it's actually been a very neglected area, this 0 to 3, those essential few years of life. And I think all through the sessions so far, we've been hearing about innovation in teaching, in thinking, in working, that we need to build upon in our solutions, because we're then starting to look at a much broader array of carers, the family, the extended family, community members, health professionals, social workers, and workers beyond traditional health, all looking to create those good behaviors and habits right at the very beginning of their life, right when it's very, very positive, rather than trying to change bad habits at 5 or 6, which is, as someone said, extremely difficult. And the other thing that this shift in narrative around this new definition enables us to do is communicate that to people and to society. So we can start saying that we've perhaps compartmentalized oral health into toothbrushing and toothpaste as a somewhat isolated and solitary activity. And the shift to oral health takes it into a much more inclusive, social, community and supportive approaches. So really broadening it up and saying it's moving out of the bathroom, moving out of this very enclosed environment into a much broader arena. And the second catalyst that the WHO resolution and strategy do is say, you know what, oral health belongs into the biggest agenda that we've got. So oral health is grounded in the Sustainable Development Agenda. And that has two really positive effects for us when we consider these solutions. First of all, as we've been discussing, oral health belongs and should be embedded and is integrated into many, many more health programs. At a global scale, HIV/AIDS, neglected tropical diseases, and as we've been discussing today, maternal and infant and child health. And that really then gives shape and form to the idea of this oral health workforce that we've been discussing. So nurses, social workers, psychiatrists, doctors, social workers, community health workers, they should all be involved in oral health. The second thing is, as we've been discussing the social determinants of health, many of the causes of social determinants lie beyond the health sector. So that we're going to have to address oral health and also health, we're going to have to work with sectors that lie beyond the health sector. So looking at upstream interventions, midstream and downstream interventions, really extending all the way through all those levels and across into different sectors. And if we start doing that, then we start looking at non-traditional oral health workers, as we've just been saying, both places, schools, places of worship, and also teachers can be all involved in oral health education. And so then that draws us back to the idea of, well, how do we educate? What should we educate on? And there's perhaps three elements. We need to look at intersectoral education. We need to teach people about health and all policies approaches. How does health impact other sectors, and how do other sectors impact health? We need to look at interprofessional education. So as many of us have been talking, how do we integrate oral health education across health workforce, but also in social care and beyond? And then transdisciplinary learning. So again, start to think about teachers and other people in other sectors who can also be a part of this extended and broadened idea of the oral health team. And as we start thinking of those ideas of education and lifelong learning, just as we address the social determinants of health, we also need to start addressing the social determinants of lifelong learning. So a yin and yang. Health and education, as we know, very, very dependent on each other. So the social determinants of health and the social determinants of lifelong learning as we start looking at our model. So what I'd like to start doing now is turn to our discussants who've come and willing to share their experiences and expertise with us today. As we start, as Richard said, start to look at some of those models, some of those ideas of solutions. So I'd like to turn to Michael Glick. Michael, you and I know each other extremely well, and you're the Executive Director of the Center for Integrative Global Oral Health at the University of Pennsylvania. And you were intimately involved in developing, I know, the FDI definition of oral health. So you're very well placed for this evening's discussion, but you've also been involved in American national oral health policy and education and research. So reflecting and drawing on your expertise and experiences around this idea of community engaged, holistic oral health care and education, what do you think some of the issues and perspectives are in terms of policy and regulation?
Thank you very much, Julian, and thank you for the invitation to join this esteemed panel. And I have been tremendously enjoyed the entire conversation since 2 o'clock this afternoon. It's been very informative, and everyone has said everything I'm going to say. So what I will try to do is sort of put it together maybe and focus it on some very specific things. So as far as I'm concerned, the biggest need right now for us in oral health is to get a seat at the table. Now, when I usually say that to people, they say, so what is the table? What seat, at what table do you want to have a seat? And that goes back to something you alluded to, Julian, and that is oral health in all policies. Whenever policies are being generated, disseminated, oral health needs to be included somehow. And I'm not only talking about health here, we talk about other things as well. We have a very interesting little series that we run out of our center here at the University of Pennsylvania and the School of Dental Medicine, where we invite big names that had nothing to do really with our health, and we talk to them about our health, and we interview them, we have a conversation with them. Last month we had Sir Michael Marmot come in and talk about social determinants of health, and last month we had a former governor of Kentucky that came and spoke to us about oral health and what he did in Kentucky when he was the governor. His son is, by the way, now the governor of Kentucky. The last question I asked him was, so give me the 15-second elevator pitch. I meet you in an elevator, I have 15 seconds. How do I convince you that oral health is important? And he gave me an answer I didn't expect. He said, Governor, this is what you're going to say. Governor, I can improve your workforce and I can actually minimize your expenses for healthcare in your state. Are you interested? That will immediately take his attention away from anything else, and he will say, absolutely, let's talk about it. If I mention oral health, it might not be that important to him, but coming forward is important to him, and figure out how what I have can help him achieve what's important to him. That's really where we need to go. And he sort of took it 2-3 steps beyond what I even thought I would be able to do. So these are important things that we need to learn. So when you talk about education, Julian, I think one thing that we don't teach our dental students or faculty is advocacy. If we want to have an impact, we need to learn how to do advocacy. We need to figure out how to get politicians and other decision makers to listen to us and figure out what is important to them. And not only what's important to them, but of course, I think we've done it backwards in many ways. In many ways, we have done all the systematic reviews and we have come up with guidelines and policies and recommendations. And then we take those and try to sell them to the policymakers. We need to change that around. We need to go to a policymaker and says, what are you interested in? And then we have to figure out what to do in order to fit into their agenda. So that's one message I have here today that I learned from listening to all these big names that we have invited to this lecture series. The other thing is that we have talked about integrating oral health into medicine and into other areas, fields. I think that with the new definition that we have, and for those who don't know it exactly, the new definition, we sort of we made it into 3 different domains. Disease, present and absence is one domain. Then we have the psychosocial aspect, and then we have the physiological aspects. And if I look at all the evidence out there today that we try to garner when we do research, we only focus on one of the domains, disease, present, absence. We need to broaden this research agenda. We need to broaden the research enterprise and include all the other things that all of you have been talking about today. And it's been very impressive, social workers, nurses, and so on and so forth, speech pathologists, and I would broaden it even more into other fields here. Those are the type of things that we need to be able to access in order to teach us, our healthcare professionals, how to be better healthcare professionals. So there's a duality here in many ways, that we need people outside our field to teach us to be better or a healthcare professional because of this extended definition that we have now of oral health. But we need evidence. And in order to get this evidence, we need to figure out how to measure things as well. So yes, we know how to measure caries and periodontal disease and oral cancer and so on and so forth. How do we measure confidence? How do we measure someone's ability to get a job? How do we measure people who perceive themselves, their own values? If I look at evidence-based medicine today and dentistry today, patients' values and preferences. Values means what's important to patients. How do we start to measure this and make it more important to us as healthcare professionals? And that's something that we need to do. Going back to what you said today about WHO, phenomenal that we managed to get WHO to start to talk about oral health and to put in this resolution that was passed. And now the global health agenda is going to be coming forth. And I think there is a webinar coming up in 2-3 weeks where we're going to actually to see what have happened through all these initiatives that have been taking place in order to move this agenda of oral health forward in the world. And that's going to be an agenda that goes from today until 2030. What they are looking for at WHO is pretty simple, but very complicated. How do we integrate oral health into the Sustainable Development Goals, into universal health coverage, and into primary health care? The intersection between those three, those are the ones we need to be able to figure out how to make ourselves relevant for. And there are principles that WHO has come up with: a public approach to oral health, integration of oral health into primary healthcare, innovative workforce model to respond to population needs for oral health, people-centered oral healthcare, not patient and not person, but people-centered oral healthcare, tailored oral health intervention across the life course. As you said, Julian, there's changes over the life course. And lastly, optimizing digital technology also for oral health. There are places today where we don't have enough oral healthcare professionals. We need to get away from our silos and the turf wars that we have. Ethiopia have 2 dentists per million people. There's no way we're going to solve the capacity issue by trying to educate more dentists. We have to figure out how to integrate other individuals in healthcare or even beyond healthcare to be able to help us. Now, all of you have talked about how to figure out how to deal with the 0 to 3. But someone even mentioned earlier, I forgot who it was right now. I think it was Dr. Hagel maybe, who mentioned that, no, we need to start even earlier. We need to start with a pregnant mother, even before they get pregnant even. So I would suggest we don't go from 0 to 3, we go from -1 to 3. Let's start much, much earlier, because if you can start to educate pregnant women, as well as husbands, obviously, or males, who can help create this much safer oral health environment for the children when they grow up, we have achieved a tremendous amount. Now, I'm going to say something that might be a little bit controversial. And Julian, you know me, you probably expected this as well. Do we actually accept the right people into dental school? I'm a recovering dean, and I have been involved in accepting students into dental school. And if I look at the people who want to go into dentistry today, at least in the United States, but I've seen it all around the world, people look at dentistry as a very nice profession that can make a good living, and you can have a very high standard in your community, et cetera, et cetera. Are those the type of dentists we want to educate? Or do we want to educate people who have a bigger interest in public and population health? Maybe we need both. I don't know the answer here. But I think we need to look at the type of individuals that we bring into our profession. And then a second thing that we need to look at is the education we give our students. Is that appropriate to the need out in the community? There is a gap, I think, between our educational efforts and the need in the community. And how do we bridge that gap? I don't know yet how to do it, but I think that we need to figure out what the needs are and then educate our students accordingly. Lastly, Ahmed, Julie, you know me, I'm a data person. I need data, we need evidence. I think we have evidence to show that oral health and health equity or non-equity go hand in hand, they go parallel. But what about other data? We need to figure out much more than just caries and periodontal disease and oral cancer and all the other bad stuff we find in the mouth. Oral health is far beyond that. We need that data. We need to be able to get patients' voices to speak up for our health as well. We need the Michael Phelps in our health. I remember there was a little small vignette where Ronaldo, the soccer player, he had an interview, and there was a bottle of Coca-Cola in front of him, and he looked at it, took it away and said, "Aqua." I think the Coca-Cola shares went down by $3 billion the next day. Those are the type of individuals we need to have to speak up for us. we will be seen to be very self-serving if we speak up for what we need in our health. We need spokespersons, we need individuals, we need patients' voices, and I don't think we have those patients' voices yet. Julian, I think I have exhausted my time here. Obviously, I can continue, but I think I want to hear other people as well. So thank you for the opportunity.
Thanks very much, Michael. And, so many good points that you raise. And I think the kind of takeaway on your very first comment was the data and evidence that we need to maybe approach people in a way that they will respond. So it's a good segue to now turn to Bruce Doll, who's the Assistant Vice President for Technological Research and Innovation at the Uniformed Services University. Bruce, I know you've got a tremendous amount of experience, both breadth and depth-wise of data and evidence. And I was wondering if you could give us your thoughts and perspectives on whether it's important that each program works towards developing the same metrics to compare and evaluate their programs, or maybe that we need to look at that each program designs its own measurements of impact tailored to its local context. What are your thoughts on that?
Julian, thank you very much. And foremost, let me thank the chairs and the entire community for having the opportunity to be here and to share my perspectives. They are a distillation of the many meetings we've had up to this point in preparation for this very excellent interchange of ideas and experience. If I may for a moment defer to my esteemed colleague who preceded me about being at the table, it reminded me of a saying that says, if you're not at the table, you're on the menu. And that is really true. And to the extent that I will not talk about knives and forks, but I will talk a little bit about tools. That is to say, what you can do to validate and some of the issues that have been raised today, both in general and particularly to Dr. Glick's comments about data and the point that if you can't measure it, it probably won't be accomplished. So think of the entire picture that we've sort of created today. There certainly is a focus on the 0 to 3 child, as well as has been mentioned before that, even occurs as a concern and an area of focus. We've also talked about transprofessional education and transprofessional practice, TPP. And then we've also talked about some of the various communities that some efforts have been made with various degrees of success, as well as individual stories. So there's a lot of dynamics going on. And these dynamics within each of those areas require personalized or customized metrics in order to assess what that can be to the contribution of our aspirations for this new definition that WHO has put out, as well as the other international society, to promote the mind, the body, the mouth, the unification of those, as it was also captured in the diagrams that you've seen as models of how we think. When you think of metrics and you think of data, I would hope you think there's a lot of ways to collect things. There are a lot of tools. And I would first assure you that the tools exist for asking the questions that we would be interested in from any of those communities, from the provider, from the beneficiary, that would further refine how we get to this higher level of awareness and accomplishment in the areas of oral health. I mean, I could talk leading and lagging indicators, you can talk binary, you can talk temporal, you can talk any number of ways to measure something. But I really want you to think about, so what? When we approach a community with what would be, hey, we're from the government, we're here to help, right? With the idea that there is a benefit we're going to provide, I always do so mentally with that community saying, so what? What are you going to do? What is the approach that then you derive the metrics that would be appropriate for measuring that? And so when I think about that, you have to really consider the number of different experiences we've had today, quite a breadth from what goes on, say, in an Indian reservation to the individualized experience of an individual and their loved one. And in considering those different situations, to Julian's question, it would be, I think, obvious that there have to be somewhat different metrics at that very specific level to assess whatever it was that was being done was effective. But there can be above those, if you will, common principles upon which we all operate, that there are then shared metrics. So you sort of have two categories that you would have to apply. When you consider those, you have to say to yourself, I'm going to try and answer a so what, but I've got to get everybody enfranchised in this. I've got to get everyone to embrace it. And to do that, you need at the basis of this a value proposition. It has to be something that the community of professionals that we've talked about, the educators, the social workers, the dentists, et cetera, all of them, and the beneficiaries or the focus of this effort have to buy into. And it isn't one dictating to the other. It has to be a collaborative effort that you get 100% buy-in in order to accomplish the value proposition. Just think of it sort of as a promise that you're going to get to some outcome at some point in time, pending the resources that you have available, and those will vary by situation, but everyone is informed and buys into that particular goal, if you will, which, if we speak generally, we're talking about not only just better oral health, but its integration into this mind-body health type of perspective. And then we have to ask, well, that's fine for looking at the beneficiaries. We also have to ask it of those who are being taught differently. We have to assess how that over a period of years, because we're talking long-term here. Even in a 0 to 3, you're talking a 3-year program, let alone are you going to follow those people? You may know of the NIH study, the 1972 class that is followed now for decades for the purposes of assessing the effects of certain practices, et cetera, that group has undergone in their growing older. So a long-term assessment also implies certain types of metrics. But the point is, first and foremost, get your value proposition for a particular community. And for, when I say community, again, those that are providing, those that are receiving, equal say in negotiating that statement in order then to move forward with the next question is, what are the metrics going to be in order to assess, did we live up to, did we accomplish that value proposition? So I relate one story. In my experience with the Navy, we do a number of isolated exercises, and they do involve communities that are in need of healthcare. Because for us, the benefit is we move equipment around in the same way we would in a combat situation. But in this case, it's with the idea that we're moving it and treating. And in the case of Alaska, there are a number of communities that are very, very in need of all sorts of care. High blood pressure is a problem, diabetes is a problem, and as I would certainly want to relate here, oral health is a problem. When we do these exercises, you have a limited amount of time. You have a 2-week window sometimes to practice what would be your standard of care on these individuals. And it involves a negotiation with that community that then creates the right expectation for what's being done. So I'll relate one particular patient, a 16-year-old girl, came in for 2 upper centrals, the most prominent teeth in a smile, were very badly decayed. She's in a situation where there is no follow-up care 2 weeks from our departure. At some indefinite point in time, she may or may not pursue care, but it's literally hundreds of miles and bad weather away. And there's a whole series of situational issues that make that look very improbable. Well, if that individual were treated here, there'd not only be the extractions, there'd be implants, crowns, etc. In that situation, there's extractions. And that individual at 16 has no central teeth, central incisors. And so if you look at that on the basis of the situation and you say, well, if the metric is I eliminated disease, you get a pretty good high score. But if you say the metric is oral health, mind, body, I'd say the score is a lot lower. The expectation in that community was eliminate disease. Given the time frame and the circumstances beyond that time frame that are than the general problem with access to care. So it's to point it, it's very important. Get the value proposition, then create the metrics, and those metrics are subject to reevaluation cyclically. But the point is that you are then in a situation with an agreement with the community that they buy in, they understand what we're working towards, make the assessments, and then obviously report out on those on some cyclical basis. So pending your questions, I again thank the chairs and the entire community for your time.
Thank you very much, Bruce. And I think your idea of a value proposition is really essential when we start to come, as you say, to look at those solutions. And picking up on Michael's comment, I think we need to look at value propositions and listen to others telling us how we should craft those or craft that value proposition. And as you say, that will depend on the local context, the local communities, but it needs to be collaborative. And I like the idea that when we think about measuring and understanding oral health and health as an inseparable entity, that we need to look at differential metrics, but also those common and shared metrics. Because I think just picking up on your little bit of humor at the beginning, we need to be at the table, but we also need to be in the classroom, which then brings me to our next discussant, Teresa Marshall. You have worked a lot in community, interprofessional education and community practice. You're a registered dietitian, and you do a lot of work and direct dental student research program at the University of Iowa. So picking up on some of the comments and thoughts from Michael and Bruce, from your perspective, what do you think the importance of educating and particularly working across professional areas when we start thinking about the definition of oral health and this more holistic idea of oral health that we've been discussing?
Thank you, Julian. In a nutshell, interprofessional education is really, really important. Individuals that belong to underserved communities are already engaged with numerous non-physician healthcare providers like social workers, dietitians, speech-language pathologists, and occupational therapists, as well as community workers, including teachers. They have established relationships that are built on trust in the communities. These existing networks of healthcare providers and community workers can be empowered to reframe oral health to address the physiological and psychosocial domains, in addition to disease prevention. To do so, the current healthcare providers, which we heard earlier, our healthcare students, and our community partners will require didactic oral health education, as well as experiential learning opportunities involving 2 or more professionals working together, so they learn how to work together. This interprofessional transdisciplinary education is necessary for the non-dentists to feel comfortable and competent addressing the psychological and psychosocial domains of oral health, moving outside of the mouth to consider the whole person, including their soul and spirit. Transdisciplinary education on the importance of oral health, best dietary practices, and oral hygiene behaviors is also necessary for the healthcare providers and community partners to deliver consistent messages appropriate to the individual community context and setting. For example, dietary messaging will need to be both culturally sensitive and doable, considering the community's food availability and their procurement resources. How might this work? As Dr. Glick just mentioned, we want to begin before birth. That's my opinion too. Most pregnant women from underserved communities engage with social workers, dietitians, nurses, and either a nurse practitioner, physician's assistant, or physician during pregnancy at prenatal visits and WIC visits. The newborn will similarly see a nurse, a family physician, or a pediatrician, a social worker, and a dietitian at their well baby exams and at WIC visits. As the children grow older, they will engage with teachers and other school personnel. Within each community, there's formal and informal networks of respected elders, but also engage with young families. Hearing consistent oral health guidance from the healthcare providers and community partners, as well as seeing these oral health best practices being modeled, is a first step towards supporting the physiological and psychosocial oral health domains and preventing disease. So yeah, we need education interprofessionally, as well as opportunities to work together. Thanks.
Thank you very much, Teresa. And you made some, really very pertinent and strong comments there, particularly, as you were saying, reinforcing Michael's point about, going back and seeing this as a continuous process. So, looking at women and maternal health and reproductive health. So a really very strong point there. And again, emphasizing the cultural and social determinants of health. So I think what we'd like to now do is maybe take some of this higher level ideas and comments and experience and really now anchor it in some community experiences from around the world. And we're very, very pleased tonight to have, or this afternoon in the US, but here in Europe, it's in the evening, two colleagues from Zimbabwe and for Peru who've been working very much along the lines that we've been discussing this evening. So first of all, I'd like to turn to Cleopatra Matanhira and then to Rita Vilena in Peru to present and perhaps talk a little bit about their experiences. So perhaps I could ask you to talk about your experiences of integrating oral health into mental health community-based programs in Zimbabwe, and then after that turn to Rita in Peru to talk about her work in over 15 years of infant oral health in communities and interprofessional collaboration in Peru. So first of all, Cleopatra.
Thank you, Julian. Good evening all, good afternoon to you all. My name is Cleopatra Matanhira. I'm a Zimbabwean dentist who is also the project lead in the Oral Health for Mental Health Patients Project Zimbabwe, a project that was initiated in 2020 by a couple of oral health professionals in the dental public health sector. The triggers for this project were that during the COVID-19 pandemic, a drug and substance abuse epidemic became rife in the country, and so did the oral health effects that were associated with drug and substance abuse. However, prior to that, in our daily clinical practice and dental outreaches, we'd also noticed that mental health patients presented with multiple oral health problems that were also well advanced. Poor oral health and mental health affect how we think, how we feel, and how we act, and the emotions that are associated with that as well. And a two-way link exists between the two. And both actually reduce the quality of life of our patients. So sadly, there was and still is a general health workforce shortage in Zimbabwe. Furthermore, specialized oral and mental health workforce. So through our professional association, the Zimbabwe Dental Association, my colleagues and I decided to apply for the FDI's World Dental Development Fund, and we got selected. The overall project goal was, and still is, transformation of oral health care of mental health patients in Zimbabwe to international best practice. We realized we could not do this alone. So what did we need to do? To collaborate with other healthcare practitioners and mental health experts to integrate ourselves into existing health programs. So we worked with the Zimbabwe College of Psychiatrists, the Zimbabwe Life Project. This is diasporans, a UK-based organizations of mental health practitioners that are Zimbabwean, but based in the UK. We worked with the University of Zimbabwe, the Departments of Oral Health and Psychiatry. We worked also with the Ministry of Healthcare and Childcare. Our targeted beneficiaries as we conducted our project were the patients themselves, the healthcare providers, the caregivers, and the communities that supported them. So the first phase of our project was actually in 2021 to 2022. And what we needed to do was to actually appreciate whether what we had seen in our practice was what was shared by our colleagues nationwide. And in the responses of the research that we conducted amongst oral and mental health professionals, it was confirmed they had noticed they were experiencing similar challenges. We went further to ask them, so if you were to be equipped, if you are to get skills to capacitate yourself, what do you need? They told us, and we formulated what we called the Oral Health for Mental Health Patients Manual for health professionals, which we then started distributing in training workshops and in addition to other health education materials. In June 2021, in June 2022, we actually managed to have an oral and mental health stakeholders briefing where we launched our project and presented it to national oral and mental health stakeholders and wanted to find out what they thought in terms of mapping the next steps. Phase 2 now of our project is what we're currently engaged in, which is the dissemination and implementation of what we've been doing. Our focus now is on the community and the caregivers and the patients as well. And how are we going to do this? We're going to start with conducting an oral disease burden and an oral disease burden assessment for the mental health patients to inform what we want to do as we're talking about evidence-based dentistry. Secondly, we're going to carry on nationwide training of mental health professionals with pre and post-training evaluations. In addition, we also want to evaluate the Oral Health for Mental Health Patients Manual that we launched. And then lastly, but not least, we also want to raise community awareness on oral health treatment needs of mental health patients. And we're going to do this through schools, through mass media campaigns, and various community health interventions through community gatekeepers. I must say, our phase 2 has become possible through the Petra project, which is a partnership of education training and research advancement, in which we're also we were selected for the mentorship research scholars program, where we're having mentors for dissemination and implementation through Stanford University and University of Colorado. So this is a summary of what we've been working on this side of the globe.
Fantastic, Cleopatra. And in a way, it's a proof of concept because you have taken what Bruce was talking about in terms of value proposition and what Michael was talking about, listening to others and then working for others. So in a way, really encapsulating what Bruce and Michael and Teresa have been talking about and saying, well, actually, we're doing this in Zimbabwe. So congratulations, a really exciting project. I'm very, very keen to hear about how it rolls out this year and next year. So with that, I'd like to turn to Rita in Peru, who's been working in maternal and infant, particularly in infant oral health for over 15 years now. So Rita, would you like to tell us what you've been doing and your experiences from Peru?
Thank you very much, Julian. Good afternoon, everyone from Lima, Peru. First of all, I would like to thank you for the kind invitation to share with you the positive results of our Peruvian experience, working dentists and nurses together. One of our objectives was to reach very young children. But why? Why very young children? Because the national data and a recent systematic review was showing us no important reduction in the prevalence of caries in children under 6 years old in the last decades, with a mean prevalence of 60% at 3 years old in Peruvian studies, a high value very similar for other Latin American countries. So it seems that starting at the age of 3 is too late. Taking into account that the national program of immunization is good in Peru with 92% of coverage, we consider that this could be a good opportunity to install a pilot model in very young children. The immunization program are in charge is part of the mother and child program where the nurses are in charge. Then it was designed a 4-year prospective study, including a previous training for nurses and dentists to work with infants. An oral health card was used as a tool attached to the immunization card to help the team to integrate the mouse during the appointments. The results were very positive, and the workforce group only had 10% of cavitated caries lesions, differently from the control group with 63%. An important fact to share is that this active group did not require specialist care, sedation, or general anesthesia, which in terms of cost benefit is very important to highlight. This model could be a good opportunity to work with health and not with a disease. Finally, I would like to leave a phrase that Dr. Walter from Brazil always said, and nowadays, after 15 years working with infants, I agree completely. It will be always better and easier to establish a good habit early in life than trying to change a bad one. Thank you.
Thank you very much, Rita. And I know we've worked a lot together, and I'm always really taken aback because you've started with your patients at such a young age. The patients love coming to see you because it's been something that they've done right from the very first moments of their life, that you're looking after their oral health. So the children know you, they spring onto their chair, and they're pleased to see you because they know that you're looking after them and you're taking care of them. So that's something that I think that you also bring to the table, this idea of the spirit and the soul and the mind and the body and the mouth, bringing the whole package together and showing just how excited and positive the children are when they come to see you. So I think you've both got the evidence, but also that sort of, if you like, the non-tangibles that go with it. So thank you very much both to Cleopatra and to Rita, I think, for sharing projects from around the world that show a lot of what we've been talking about is transferable, as Bruce was saying, common principles that can be applied and transmitted and applied in many circumstances and communities around the world. So what I'd like to do is keep that theme of community engagement in value proposition and turn to Judith Amino. You've done a lot of work with Indian Health Services during your time at the Colorado School of Public Health. Drawing on some of your experiences and some of the work that you've been done, what are your thoughts on how oral health program can address the social determinants in a more structured way?
Now I'm on, so thank you, Julian. I would like to address that. I think because we've alluded to social determinants and the importance of social determinants, how we know that it goes beyond the domain of health and healthcare in terms of all of the factors that influence the way someone approaches their health issues. And I would say that what we need to make sure we're doing above all is that we are staying completely open to learning more about the social determinants of whatever community, whatever group we are planning interventions or programs for. Probably the most important lesson I learned in working over a number of years with American Indian communities, two large tribes, was that was really about how little I knew about their culture, about their lives on a day-to-day basis, and about the way the structure of their lives, the way they go about living their lives, and where they are with respect to their cultural issues vis-a-vis health and a whole range of other parts of life, and that I really knew nothing about that, and that it was so presumptive to me to assume that I could develop a program, offer an intervention that would meet their needs. And so what I'm saying is we have to get that input up front. What better way to learn about a group, about a community, than to ask them, to bring them in and helping to plan the programs. So that's my strongest advice there. My experience is all out of the research side, but research aimed at developing programs, developing and testing interventions. But that is certainly what we learned, that we need to have that consultation early on, to ask members of the community what's important to them and what do they most need, and what are the obstacles, the barriers to their accessing programs, and not just to assume that if we build it, they will come, so to speak. I would like to, if I may, Julian, just hit very quickly on two other things that I think are related, and they're following up on things that have been said today. But you mentioned the importance of a lifespan approach, and I think that's also something that we have to do in planning any programs, and that is remembering that we have to, that the needs are different at different stages of life. And I certainly absolutely embrace the idea that we have to put a lot of effort into understanding what young children need. I'd say, Rita, that it's not just 3 is too late, 2 is too late. And so we've really got to focus there. But the other piece, and we've made some progress in the US with younger children, but where we have not made much progress is with older people. And that is going to be something that can just almost overwhelm us in the coming decades. We'll have, within the next 10 years, we'll have more people in the United States over the age of 65 than we have young people. And we need to pay attention to that. We need to think about what their needs are. And the most extreme cases, some of which we've heard about today, but also just what the issues are and the problems for our aging population. And then finally, very quickly, I think that we need to embrace every possibility in terms of new models of providers. There is a reason, and we heard from Bruce, a great example of what you would see in Alaska, for example, and the inability to get follow-up care. But there is a reason that that dental therapists have perhaps received their highest development in the United States in the state of Alaska, because there, when you are talking about the situations in the far north and the Alaska Native villages, we're not talking about mid-level providers who would substitute for dentists. We're talking about mid-level providers who substitute for no dental care whatsoever. And to be able to bring that model in and develop that model has been something I think we can all learn from, and there are other communities who can use that as well. But not just that model, we need to think about all of the different ways of using providers and across the training disciplines as well. I'll stop with that. I know I'm taking more time than I should. Thank you.
Thank you very much, Judith. And I really like the idea that you talk about not having preconceived ideas of the social determinants. You know, picking up on Teresa's point, you know, we really need to look at experimental learning in terms of the social determinants, and we go in and we listen to how the community describes their own social determinants, rather than going in with a prescribed list that we kind of tick on, or we try and squeeze them into preconceived boxes. And with that idea, maybe turning to Lisa again, you know, you were mentioning and you were talking about your community-based, community-engaged ideas around the social determinants. Do you want to add anything to Judith's comments around the social determinants?
I'm going to add, I'm just going to reiterate a few things too. I mean, to Judith, but also to Rita, what she was saying, you know, it's good to establish good habits early in life. And then Judith was saying how, yeah, everyone's needs are different throughout the life cycle. And I do agree, you know, those early years, those formative years, I think it's also critical, you know, those caregivers providing care for those, you know, young children. It's important to involve them in those conversations as well. And I think another thing that I think is critical is, like we're saying, our messaging needs to be culturally sensitive. We need, it's, you know, meeting people where they are. And I think that was something that Judith said that I fully agree. You know, we come in with grand ideas of how we're going to create this great programming, but you know, what do they need? What do they want? Involving them in that conversation. And I also think we have a tendency to do a bit too much oftentimes. So providing with like bite-sized, you know, palpable information that, you know, that just doesn't overwhelm them all at once. Because oftentimes I say, you know, just one achievement, something minor, again, it gives them that enthusiasm to keep moving forward. Whereas you overwhelm them with too many things, that it feels like failure or something.
That's right. And particularly with children, you know, just doing one thing and they get, you know, small successes, exactly as you say, Lisa. I think trying to do too many things sometimes overwhelms people, whereas if you stick to something very small and doable, they get you know, success, and it motivates them to move forward. So I think some really excellent points. I'm just very conscious of the time. So I'd like to sort of bring in Jeff Stewart, who's the Senior Vice President for the Interprofessional and Global Collaboration at the American Dental Educators Association, and maybe picking up on what Rita and Cleopatra were talking about working with other health professionals, learning with and from experiences and programs around the world, and whether you've got any sort of reflections or comments on the conversations and some of the input that we've had this evening or this afternoon.
Thank you, Julian. I guess one of the disadvantages of going last is a lot of my thoughts have already been expressed by others. So I'll just share a few thoughts about interprofessional education that I guess will endorse some of the very good comments that we've already heard this afternoon. Most recently by Teresa, who underscored just the importance of interprofessional education as we move forward with attempts to solve some of the issues that we're discussing. So just a thought, healthcare education must occur in places where our learners spend time participating in true, effective, team-based care, with oral health learners experiencing the provision of oral health care in a comprehensive and integrated fashion. And clearly this means that oral health care must be available in the same locations as where other healthcare services are being provided. And as we all know, this is mostly not the case. Secondly, there must be enhanced efforts for interprofessional development for the existing healthcare providers, not just the current learners, so that the existing healthcare workforce becomes competent in interprofessional and collaborative care in areas such as teamwork, roles and responsibilities, interprofessional communication, so that they are providing and modeling the provision of healthcare in a truly team-based and integrated approach. And then finally, just that, you know, we need to learn from those exemplary interprofessional education models and interprofessional competency sets outside of the United States that we can see are successful in promoting integration of oral health into overall health, and even extending our educational models to include sectors outside of traditional healthcare that we now know have impacts on the health of people, communities, and populations. Thank you, Julian. I will turn it back to you.
Thank you, Jeff. And I think you've encapsulated, particularly around the education sphere, a lot of those key points about being open and willing to hear and listen and to learn from others. So I think a really, very pertinent and key message to end on. And so what I'd like to do is hand back to Richard and to Patricia as we're coming to the closing stages of the meeting.
Yeah, so I'd just like to, again, thank everybody. I mean, this is really enlightening. I think to sum it up is it's to be successful, the consumer, the individual, the person, whatever name you want to put on it, has to be the center. And that means they have to be the center of the idea, and they have to be the center of getting what they want, as we heard from the politician to the finance person to whatever. The individual in the community is looking for something that they call success, whether it's reduction of pain or whether it is being able to play sports or whatever it is. And we have to meet them there. Somebody else said it. And we can learn from those examples that we've heard about today that are successful. And so I would say quickly, as I turn it over to Patricia, thank you all. This has been a really stimulating, wonderful day for me. Hope it's been half as good for you all. And I think we're on to something very good. And if we do what we say, which is to listen, and then take the benefits of everything that we have learned that works and measure it, we could really do something really important and great. So thank you.
And back to the co-chairs for the final remarks. Thanks.
Thank you so much, Patricia. Thank you, Julian and Richard, for leading such a wonderful session, and to our panelists for sharing all of their wisdom today. For me, this has been a groundbreaking workshop. We have heard clearly why community engaged approach is essential to address oral health. We've learned from each other, and we have begun not just to envision the new educational model, but learn the many small bites, and I love that phrasing, of oral health that are already being incorporated within other health professions that share our interest in improving oral health, and doing it in a way that recognizes social determinants of health. Of course, there's a lot of work to be done, but I think this is a moment in time that is filled with opportunity. A moment that really recognizes that collaborating with a wide array of others, and in doing so, dentistry will not compromise its traditional role, but in fact expand it in a meaningful and effective way. So I'm very grateful to the Academies for giving us this opportunity. I hope that you all feel as invigorated as I am today. Thank you for all your insights, your participation. Have a wonderful afternoon or evening, wherever you might be. And Mayumi, I'm sorry. Thank you for being such a wonderful co-chair with me. I'm turning the mic over to you. Thanks, Mayumi.
Thanks. Well, I can't really top that, Isabel, but I will say that as a firm believer in collaboration across health professions and team-based care, it's been really exciting to listen to all of you coming from different professions, approaching these issues through your own unique disciplinary lens, yet all of us working towards a common goal. I'm really grateful to all of you for sharing your perspectives and stories. Thanks for giving us the space to for all of us to learn from each other and put our heads together on how we can leverage our own expertise while recognizing our own positionality around oral health, health promotion, social determinants, to prepare our next generation of health professionals for high quality healthcare delivery, as well as impact the health of our most vulnerable individuals, families, and communities. So like Isabel, I've been really energized and inspired by all the dialogue. I also love the little bites. It feels much more manageable. And I'm really excited to see our next steps. Just so you know, today's workshop was recorded and will be posted on the forum's website. There will also be some written proceedings that will also help inform our next steps. So In closing, I just want to say thank you to CareQuest again, the planning committee, all of the panelists, particularly Patricia and Hannah Goodtree for their dedication and passion and amazing organization. Yes, applause to them. All the speakers, and to all of you for staying with us for the last several hours and really giving us an opportunity to figure out what we need to do next. So thank you very much. Have a great afternoon, and hope to see all of you on Zoom in some way soon again.